All right, so this is the blood chapter. The blood typing information I've done in separate videos, so you'll look at those videos for that information. Now, we learned in Anatomy 1 that blood is actually a type of connective tissue. It's a fluid type of connective tissue. It's made up of plasma, which is the fluid portion of the blood, and then some elements, which are your blood cells. The erythrocytes are the red blood cells, leukocytes are the white blood cells, and the platelets, which are also called thrombocytes, are also another type of cell in blood. Hematocrit is the percentage of your blood volume that's made up of red blood cells. Now, that's going to be higher for males than females. It's approximately 47% for males and 42% for females, with a range of plus or minus 5. It's higher for males because they have more testosterone, and testosterone increases a hormone called erythropoietin. If you remember from the last chapter, erythropoietin is what causes erythropoiesis, which is the formation of red blood cells. Number of components of blood is the pH of blood being 7.35 to 7.45. That's your normal physiological pH. Super important. I underline that for you here. Some other things that I probably won't ask on a test, but components of blood, the temperature is about 100.4 degrees Fahrenheit. The weight of blood accounts for about 8% of your body's weight. It's about 5 to 6 liters for males, 4 to 5 for females. So in functions of blood, we have distribution. It's going to deliver things: oxygen to tissues, nutrients to body cells, also delivering metabolic waste to things like the kidneys and lungs, transporting hormones, other chemical messengers, neurotransmitters, things like that. The blood also helps maintain body temperature by absorbing and distributing heat. It maintains normal pH by having buffers in there. We're going to talk a lot about this in the future chapters. Also maintaining adequate fluid volume because we can move fluid in and out of the blood. There are protective functions of blood. One aspect of protection is preventing blood loss. So we have things like platelets and plasma proteins that are going to cause clotting and prevent blood loss. We have other things that prevent against infection, things like antibodies, complement proteins, different types of white blood cells. Your blood plasma, as I said, is the fluid portion of your blood. It does have some other components in it, but not cells. The cells are the separate portion. And your blood is 90% water. The primary blood protein that you have is called albumin, although there are a number of proteins in the blood. Now, when we look at the different types of blood cells, you have the erythrocytes, the red blood cells, which are not complete cells because they don't have any nuclei or organelles. We have white blood cells, which are complete cells, and there are 5 different classifications of white blood cells we'll go through. And then platelets, which are actually not complete cells either because they're fragments of this larger cell called a megakaryocyte. Characteristics of red blood cells: they are biconcave discs. What does that mean? Well, I'll show you on the next slide. There's a picture where you can see this kind of concave portion on both sides of the red blood cell. What this does is it increases surface area. Well, red blood cells' function is to carry gases, oxygen, carbon dioxide, and deliver them to tissues and lungs. And so diffusion is a primary function. And the more surface we have, the more effective the diffusion is. So that makes sense that this structure determines function, right? So it's built to do what it does and do it well. It's also anucleate. That means it does not have a nucleus. It doesn't have any other organelles as well. It's primarily hemoglobin filled inside the red blood cell. And it's also the major factor contributing to blood viscosity. Now, when you think of viscosity, think of thickness and stickiness. So the higher the percentage of red blood cells, the thicker and stickier the blood becomes. Here's the picture that I referenced, and you can see that biconcave disc shape. So we already mentioned that the erythrocytes have a biconcave shape, right? They increase surface area. We said they're primary hemoglobin, so over 97% of what's found inside the red blood cell is hemoglobin. Again, no organelles, including mitochondria. Well, mitochondria is where we get most of our ATP through the processes we'll cover in chapter 24. So how does the red blood cell get its energy? Well, it uses anaerobic glycolysis, and this happens in what's called the cytosol, and the cytosol is going to be the liquid portion of inside the cell, right? The cytoplasm is the organelles plus the fluid. Well, there's no organelles in erythrocytes anyway. but the cytosol is that fluid portion, and that's where glycolysis can happen, so you don't need a mitochondria for it. And it's also anaerobic. What does that mean? It doesn't use oxygen. This is good because a primary function of erythrocytes is to carry oxygen, right? So if I was an ice cream truck driver, this would not work very well because I like ice cream. I would eat all my product, right? So the same thing for red blood cells. If they had to use their oxygen that they're carrying, that wouldn't be effective. So they can actually generate ATP without oxygen. Makes sense. Again, structure determining function here. It's a really good example of how we build something to be efficient at what it's supposed to do. So the function, as I said, of the red blood cell is to carry these gases, oxygen and carbon dioxide. And what's going to happen is you have the hemoglobin, as we mentioned, inside the erythrocyte. Each hemoglobin has 4 heme groups. Each heme group has an iron, and that iron binds up to 1 oxygen or O2. And so each hemoglobin can carry up to 4 O2s. Now, if you look at it, each red blood cell contains about 250 to 280 million hemoglobin molecules. So again, it's a massive amount of gas transport for even just one red blood cell. When we have oxygen loading in the lungs, it produces what's called oxyhemoglobin, which gives a bright red appearance or a ruby red appearance. The O2 unloading in tissues produces deoxyhemoglobin, that's a darker red. And carbon dioxide loading in tissues is called carbaminohemoglobin. And it's when carbon dioxide binds to the hemoglobin. Now, by the way, the carbon dioxide and the oxygen bind to the same site. They both bind to the iron on the heme group. So there's 4 slots. So if you think about it, if we bind a carbon dioxide to one of those 4, then there's 3 slots left for oxygen. If you bind it to 2, there's 2 slots left. Hematopoiesis, sometimes called hemopoiesis, is blood cell formation. Poiesis actually means formation, and hemato or hemo means blood. So hematopoiesis is the formation of blood cells. Now, it occurs in red bone marrow, which is in the axial skeleton and girdles, also found in both the proximal epiphysis of the humerus and the femur. Now, that's where the red marrow is. That's where hematopoiesis occurs. The stem cell that all of those cells come from is called a hemocytoblast, sometimes called a hematopoietic stem cell. If hematopoiesis is the formation of blood cells, then erythropoiesis is the formation specifically of red blood cells. It's a type of hematopoiesis. If we have too few red blood cells, it can lead to decreased oxygen to the tissues called hypoxia. If we have too many, we mentioned before about that increasing blood stickiness, right? That viscosity. And then the erythropoiesis is going to be the balance that causes red blood cell production to keep us within homeostasis between those 2 areas, right? So we don't become hypoxic and we don't have too high blood viscosity. Now, there's approximately 200 million red blood cells made per second. And again, the balance of making these red blood cells, now they die, right? We're going to talk about later, they have a shelf life. They don't reproduce the red blood cells. They die. We get rid of the remnants and recycle things like the hemoglobin. But it's based on the production versus destruction is based on hormonal controls, also nutrients like iron, amino acids, B vitamins, and things of that nature. Now, while I'm not going to test on all of the cells that go through the stages of red blood cell formation, what I do want to illustrate is that we start off with a hemocytoblast, again, the stem cell for all blood cells, and eventually we get to the erythrocyte. Also, you can see on this picture where the red blood cell, it ejects the nucleus before it gets to its final stage. I like when terminology matches. We have erythropoietin, a hormone that causes erythropoiesis that forms erythrocytes. So erythropoietin is the hormone we said made by the kidneys, and it's going to cause the production of red blood cells. Now, what causes it? Well, again, hypoxia, low oxygen, stimulates, okay, we need more red blood cells to carry more oxygen. There's a number of reasons for hypoxia. Some I have listed here: hemorrhage or increased red blood cell destruction, insufficient hemoglobin, different types of anemias that we'll talk about later, like iron deficiency, reduced availability of O2 at high altitudes. These are all things that would stimulate erythropoiesis or the production of erythropoietin that would cause erythropoiesis. As we said, EPO causes the production of red blood cells, EPO being erythropoietin. And this is one of the ways that athletes blood dope. They use their artificial erythropoietin, and what it does is it raises the level of red blood cells. Now, we normally have homeostasis, right? So when we hit enough red blood cells in our body shuts it down through negative feedback. However, if you inject additional EPO at that point, then you're going to produce more red blood cells. The danger is, of course, it increases blood viscosity, and that can lead to blood clots and a number of other, adverse effects. Now, testosterone, I mentioned a little bit earlier in this chapter, enhances erythropoietin production, and by doing that, it increases erythropoiesis more so, and so males having higher testosterone are going to have higher red blood cell counts. We saw that on that slide with hematocrit. And this just gives you a visual of the homeostatic balance with red blood cells maintaining that normal blood oxygen level. There are lots of components that go into making a red blood cell, like amino acids, lipids, and carbohydrates, all your macronutrients, but also some micronutrients like B vitamins, B12, folic acid, both being classified as B vitamins, both necessary for DNA synthesis, and then also iron being a big one. Iron, 65% of it is found in your hemoglobin, and the rest is found in liver, spleen, and bone marrow. We have a number of different types of proteins that either store iron or transfer it. A storage form of iron is called ferritin. The overload storage form of iron is called hemosiderin. And iron is transported by a protein in the blood called transferrin. I have the normal levels of ferritin down here. You do not have to memorize these numbers. It just gives you the ranges of normal. And remember, ferritin's your storage. So just because the storage is low doesn't necessarily mean you have anemia. There are stages that you go through of iron deficiency. So you may not be that progressed even if the storage levels are low. But obviously that's a little bit of a red flag that you need to possibly ingest more iron. So the lifespan of a red blood cell is about 100 to 120 days. They get old, fragile, the hemoglobin starts to degenerate, and so when the red blood cells die, we send macrophages over to engulf them and get rid of all the debris. We take the iron and we salvage it to reuse it. In fact, we only lose iron in the body through blood loss, and so iron will always get recycled otherwise. One thing I want to emphasize on this slide is, well, the definition of anemia is an abnormally low oxygen carrying capacity, but I want to emphasize that it is a symptom, not a disease. So anemia is not a disease, it's a symptom, and that low oxygen carrying capacity causes some signs and symptoms from this anemia, like fatigue, paleness, shortness of breath, chills, things like that, and that's due to that low oxygen level. Causes of anemia, we have hemorrhagic anemia. That's blood loss. So, for example, would be a stab wound or any injury, whether it be internal or external bleeding. It's going to cause blood loss. Treated with blood replacement, that's pretty straightforward. Chronic hemorrhagic anemia, this is a small amount of blood loss, but it's persistent. So it's more of a chronic situation where it's small amounts over a long period of time. Things like hemorrhoids, bleeding ulcers, these are things that can eventually cause enough blood loss to lead to anemia. Iron deficiency anemia. Iron deficiency is actually the most common nutrient deficiency. And iron deficiency anemia, I won't go through the stages here. It's more something we cover in nutrition class. But there are stages to get to this point. What causes iron deficiency anemia? Well, blood loss, right? Because iron's in the hemoglobin, which is in the red blood cells. So if you lose blood, you lose the iron. If you have low iron intake, or if you have something impairing the absorption of iron. The iron deficiency anemia is a microcytic hypochromic type of anemia. Hypochromic means the cells are pale. Microcytic means the cells are small. Some types of anemia are macrocytic, like a B12 or a folic acid deficiency would cause macrocytic types of anemia. The treatment for iron deficiency anemia would be iron supplements, also ingestion of more iron-rich foods. Another thing to realize is we have heme iron and non-heme iron. Meat has both of these. Plants only have non-heme iron. Heme iron is much better absorbed for a variety of reasons that I won't cover in this class, but it's a lot better absorbed. So if you're on an all-plant diet or plant-based diet, as far as vegetarian or strict vegans, they need to make sure that they're getting enough iron, from their foods. Okay, so pernicious anemia. Now we said anemia is a symptom, not a disease, but a disease that can cause, or is a primary cause of pernicious anemia, is an autoimmune disease called atrophic gastritis. Now I corrected this in the notes because the way it was in the original PowerPoint notes made it look like pernicious anemia was the autoimmune disease, but we know anemia is not a disease, right? So what happens with atrophic gastritis? Well, it damages the cells that make intrinsic factor. And intrinsic factor is a protein that is needed to absorb 99% of your B12. 1% of your B12 can be absorbed passively without the help of intrinsic factor. Now, you only need about 2.4 micrograms per day to meet the RDA for B12, so it's a small amount, but what you have to realize is if you're only absorbing 1%, that if you have this pernicious anemia, or this atrophic gastritis, I should say, it's easy to eventually get to a state of anemia where you're lacking the B12, which we said both B12 and folic acid are necessary for DNA synthesis, necessary to make red blood cells. So this is a macrocytic type of anemia, large cell type, compared to the iron, which was a microcytic type of anemia. Now, how do we treat B12 deficiency? Well, injections, sublingual, or nasal gel. Now, if you are deficient, long-term B12 deficiencies can lead to permanent nerve damage, so you want to get the injections to get the B12 storage back up. It's the only B vitamin that actually stores in the body. It stores in the liver. So you want to get your storage back up as quick as possible. Then you can maintain it with either regular injections, sublingual, which is daily, or nasal gel, which I believe is weekly. Some people that may be at higher risk are strict vegetarians or vegans, because B12 is only found in meat. When it's found in other sources, it's a non-usable form, or plant sources. I believe there's some, possibly, I think it's brewer's yeast. It's an unusable form of B12. So you have to get it from meat sources or enriched sources, right? So we enrich some of our grains and foods with B12, or you have to get it from a supplement. And as I mentioned before, 1% of your B12 gets absorbed passively, so it does not need that intrinsic factor. Renal anemia is a lack of erythropoietin. We said that the kidneys make erythropoietin. When you think renal, think kidney. And if you can't make enough erythropoietin, of course, then you would not have sufficient erythropoiesis, so it would be treated with synthetic EPO. Aplastic anemia is destruction or inhibition of the red marrow. This can be caused by a variety of things: chemicals, radiation, drugs, even viruses. The cause, though, is usually unknown, and it would be treated with transfusions in the short term and long term transplanted stem cells. Hemolytic anemia, lysis means to break, hemo means blood, so hemolytic anemia is anything that causes premature lysis or breakage of red blood cells. Some things that can do that would be abnormalities of the hemoglobin, incompatible transfusions, which we'll talk a little bit about at the end of the chapter, and I talk about in the blood matching videos, or infections could potentially cause that as hemolysis as well. Thalassemia, this is a type of anemia that's genetic. It's the most common genetic disorder worldwide. It generally or typically occurs in individuals that have a Mediterranean ancestry. The red blood cells become thin, delicate, and weak, and they break real easy, so you wind up with a deficiency in hemoglobin. Sickle cell anemia is due to two defective genes for abnormal hemoglobin, the HbS gene. If you have one, you have what's called sickle cell trait. Sickle cell trait actually developed in areas where there was high malaria rates, and it actually gave them, the individuals, resistance or immunity, or some immunity, to malaria. The problem was when mom had the trait, dad had the trait, if they both passed down that sickle cell trait, that one gene, and the child got both defective genes, they ended up with sickle cell anemia. It makes the red blood cells sickle-shaped, so they're not effective at carrying oxygen. They also lyse very easy. They break very easy. So again, you wind up with anemia and anemic symptoms. The disease occurs in about 1 out of every 500 African American births. And African Americans have the highest percentage of sickle cell anemia due to the fact that the sickle cell trait originated in areas in Africa where it was high rates of malaria. This just gives you a nice visual of a normal red blood cell versus a sickle cell anemia red blood cell. Polycythemia. Polycythemia is, poly means many. This is too many red blood cells. Now, we have polycythemia vera, which is a bone marrow cancer. This is due to excess red blood cells. We said that if we have too many red blood cells, it would increase blood stickiness, right, and thickness, that blood viscosity. If you want to get a nice visual of this, think about drinking, iced tea through a straw versus taking the same straw and trying to, drink a very thick, milkshake, or chocolate shake, trying to get it through that same straw. It's going to be thicker and harder, and you're going to need a lot more force to pull it through that tube, right? So we don't want that to happen in the bloodstream with the viscosity. Now, the cause for polycythemia vera, as I said, is bone marrow cancer. Secondary polycythemia, we have things like living at high altitudes where there's less oxygen available and EPO production increases. Blood doping is another example of having secondary polycythemia, right? Injecting the artificial EPO that we talked about earlier. Another way that individuals do blood doping is they can take out their packed red blood cells, their body brings their red blood cells back to normal, and then they inject the red blood cells back in before whatever it is, whatever competition or whatever they're doing it for. So either way, we're seeing a high level of red blood cells. Now, if I were to ask on an exam, what are the causes of polycythemia, and I left it general, then it's any of those three that I just talked about, right? If it's polycythemia vera, we stick with bone cancer. If it's secondary, we stick with high altitudes and blood doping. Leukocytes are white blood cells, and we said they're the only complete cells, right? Because the red blood cells didn't have the nucleus or organelles, and the platelets that we'll talk about were only fragments of cells. The white blood cells are much less numerous than red blood cells. They're about 1% of your blood volume. They have some specific things that they can do, like this thing called diapedesis, where they can move into the interstitial space through the capillary walls. They usually only live a few days. We do have lymphocytes that are memory cells that we'll talk about in the immune system that can live for months or even years. Now, a couple of terms to be familiar with. Leukopoiesis is formation. I don't have it on this slide, but I have it later. But leukopoiesis is formation of white blood cells. Leukocytosis is an increased production of white blood cells. Things like an infection, whether it be bacterial or viral, can cause it. Surgery, anesthesia, exercise are all other things that could potentially cause an increased production of white blood cells. And we're going to talk about the different types of white blood cells as well. Penia means decrease, so when you see the word leukopenia, it means decrease in white blood cells. Now you have granulocytes and agranulocytes, and that depends on whether they have granules in their cytoplasm. Well, neutrophils, eosinophils, and basophils all have all granulocytes. They have these granules in their cytoplasm. The ones that don't, A means without, so agranulocytes are the lymphocytes and the monocytes. Now, there's a really good mnemonic. It's never let monkeys eat bananas, and that gives you the 5 types of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. The other great thing about this mnemonic is that's the order of abundance that they occur in the blood. So the most abundant is going to be the neutrophils, the least abundant is going to be the basophils. So our mnemonic tells us that neutrophils are the most abundant, right, of all the white blood cells. They have another name. They're called polymorphonuclear leukocytes. Try and say that quick 3 times. That name actually, though, it sounds really complex, but poly means many, and then the morphonuclear, they have these multi-lobed nuclei, so many lobes to the nuclei. And so the name does make some sense. I'll call them neutrophils, of course, when I test. They do have hydrolytic enzymes or defensins that help kill bacteria. These are phagocytic cells as well, so they'll perform phagocytosis and engulf bacteria. And they're about twice the size of red blood cells. So while the neutrophils were multi-lobe nuclei, the eosinophils have a bilobe nuclei. And these are specific for things like parasitic worm infections, allergies, asthma, and that's where you're going to see the production of eosinophils. Basophils, they're going to be the least abundant of the white blood cells. These are going to release histamine. Histamine is an inflammatory chemical. It also acts as a vasodilator. We'll be talking about histamine again. And histamine is released by the basophils, which is why we say that the basophils are similarly functional to mast cells, because mast cells will also release histamine. Here's our multi-lobed nuclei. So we're looking at a neutrophil here. With the eosinophil, you can see these two specific bilobed, or the bilobed nuclei. There's two specific lobes of the nucleus. This is a basophil. To me, it looks like a fragmenting planet or asteroid. Sometimes it looks even more so like that, depending on what slide you're looking at. And this is a basophil. Lymphocytes, these we're going to talk a lot about in the immune system chapter because they're part of they make up the adaptive immune system. We have some different types that we'll talk about. The two primary classifications of lymphocytes are T lymphocytes and B lymphocytes. And just to give you some basics for now that we'll build on later, the T lymphocytes are going to act against virus-infected cells and tumor cells. And the B lymphocytes are going to differentiate into what's called plasma cells, and those plasma cells are the cells that produce antibodies. Monocytes are the largest of all the leukocytes. Now, something to be really careful of is not to confuse lymphocyte with leukocyte, right? Lymphocyte is a type of leukocyte. All 5 classifications of these white blood cells are leukocytes. So leukocyte is just white blood cell. So monocytes are the largest. We said that the neutrophils are the most abundant. These are the largest in size individually. And they're going to differentiate into macrophages, and we know from the past, at least in Anatomy 1, macrophages are phagocytic cells, right? They can engulf bacteria, viruses, things like that. We even mentioned how they would get rid of the debris of red blood cells once they die. This picture shows a small lymphocyte. You can see the comparison between a red blood cell and this lymphocyte. Sometimes they're about the same size or just a little bit bigger, and the nucleus, at least in a small lymphocyte, takes up a very large portion of the cell. This is probably not the best visualization of a monocyte, but we do have a large cell here when we look in comparison to the red blood cells surrounding it. This doesn't give you a kind of a panned out view. And that nucleus almost looks like it could be an eosinophil, but that's not bilobed. That's actually just, it looks a little bit like that in this slide, but it's not. This is actually a monocyte. So we said leukopoiesis is production of white blood cells. Leukopenia is a decreased production. We said in the other slide leukocytosis is an increased production. Now, what is leukemia? Well, leukemias are types of cancer. You have myeloid leukemia, which involves the myeloblast. You have lymphocytic leukemia, which involves the lymphocyte. And what it is, it's an overproduction of non-functional white blood cells. So it's not an underproduction. Actually, we're producing too many, but they're not functional. When it's acute leukemia, it comes from the stem cells and usually affects children. Chronic leukemia usually occurs in older adults. Now, when you have this overproduction of the non-functional white blood cells, what it can do is it can even crowd out, besides the fact that they're not functioning, these lymphocytes, right, if it's lymphocytic at least, we're also going to crowd out other cells, right? So we'll crowd out some red blood cells, which can lead to anemia. We can crowd out platelets, which we haven't talked about yet, but they're important for clotting, so this can lead to bleeding. So the death from leukemia usually occurs from internal hemorrhage or from an overwhelming infection. Drugs to treat it, you have anti-leukemitic drugs, you have stem cell treatments for transplants for treatment, and also radiation treatment. Now, this is a complex slide that I wouldn't spend too much time on, but we again can see that we start with the hemocytoblast, and then we can go off into a number of different pathways. And you can look down at the bottom, and you can see the 5 different types of white blood cells with the lymphocytes split into 2 different classifications with T and B lymphocytes. So, infectious mononucleosis, it's viral, and it's highly contagious. It is actually caused by the Epstein-Barr virus. Some symptoms you will see that occur with mononucleosis are fatigue, achiness, chronic sore throat, low fever, persistent low fever, and usually this runs its course with rest. Platelets are called thrombocytes, and we said, are not complete cells. They're fragments of a larger cell called a megakaryocyte, and their function is in clotting. So what they do is that they form a temporary platelet plug that seals a breakage in a blood vessel. Some other aspects of platelets is they do age quickly and they degenerate in about 10 days, which is good because they form clots, right? So we don't want them forming clots in something that's like a blood vessel that's not broken. That would be a problem. This shows the pathway with the platelets, starting with the hemocytoblast, ending up with platelets. You can also see how it's a fragment of that large cell called a megakaryocyte. Now, bone marrow transplants, remember, red bone marrow makes blood cells. So if you have someone that needs a bone marrow transplant, they're receiving this bone marrow, and it takes about 2 to 3 weeks to start producing white blood cells to fight infections. But one of the dangers that you encounter is what's called graft versus host disease. The transplanted marrow in this case can produce T cells that attack the host tissue. So when we give, and I say this when we talk about the blood typing, but when we're giving someone blood, it's us. If the blood's not a match, it's us that attacks the blood. Even though it affects the person's body, it's their body attacking. Their antibodies attacking the foreign blood. In this case, it's actually the foreign or the transplant attacking the host. Another type of transplant, you have the cord blood transplant. This is stem cells used from an umbilical cord, and they can be collected and stored indefinitely. The benefits are much less likely to cause graft versus host disease. Hemostasis, not to be confused with homeostasis, although it is a homeostatic mechanism to bring us into balance. Hemostasis means the stoppage of bleeding, which makes sense that is a type of homeostasis, right? Because if you're losing blood, you want to stop the bleeding so we can maintain, the volume of blood. There's a number of factors required for hemostasis, including clotting factors, platelets, and we're going to go through the steps. So there are 3 essential steps to hemostasis: vascular spasm, platelet plug formation, and coagulation. Vascular spasm is really straightforward. It's vasoconstriction of the blood vessel, and what that does is it minimizes blood loss at the breakage, because as we make the tube smaller, less blood's going through it. That vasoconstriction happens immediately, and then we have what starts is the platelet plug formation, and this is a positive feedback cycle. So what's going to happen is the damaged endothelium of the blood vessel exposes collagen, and the platelets are going to come to the area, and they're going to stick to the collagen. And there's a prostaglandin called prostacyclin, and that chemical actually keeps the platelets in that area, which is good because we don't want them just going and sticking to collagen anywhere, right, or causing clots in places they shouldn't. So it keeps the platelets in that area. And by positive feedback cycle, the platelets release chemicals that draw more platelets, that release more and more and more, and we kind of build up lots of platelets until we form this platelet plug that I'll show you on the picture. And then again, that plug helps the stop the blood loss. So before we review it on the picture, we have 3 phases of coagulation. Coagulation being the 3rd phase of this hemostasis. We have something called prothrombin activator that gets formed. It goes down one of 2 pathways, an intrinsic or extrinsic pathway that you can look at in your textbook, but I don't go into detail here or even for testing purposes. Prothrombin then gets converted to thrombin, and then thrombin catalyzes a reaction that joins the fibrinogen to form a fibrin mesh network. So if we review this, we have the vascular spasm or the vasoconstriction, the platelet plug formation with the platelets coming and sticking to the collagen. You can see that in step 2. And then the coagulation where the fibrin forms a mesh that traps the red blood cells and platelets. And then what we're gonna do is something called clot retraction. So the clot retraction is going to stabilize the clot. What's going to happen is it's going to pull the fibrin strands, it's going to squeeze the serum out of the clot, and it's going to draw the edges of the blood vessel together. And then, of course, the vessel heals, and at the same time as, and repairs at the same time as this clot retraction is happening to get back to normal homeostasis. 3 types of hemostasis disorders are thromboembolic disorders, bleeding disorders, and DIC, which we'll cover each of these in the following slides. Now, we said the platelets form a clot in a broken blood vessel, but if we form a clot in an unbroken vessel, it's called a thrombus. Of course, the danger with this clot is that it can block blood flow. And if you block blood flow completely, it leads to tissue death. An embolus is essentially a thrombus that is broken free and is floating in the bloodstream. So, and now arteries diverge, so they branch and they get smaller and smaller and smaller. So eventually what's going to happen if an embolus does break off, it's going to lodge into a small artery and block the blood flow to wherever that artery is going. If it blocks an artery to the lungs, you can have a pulmonary embolism. If it to the brain, a cerebral emboli, which can cause a stroke. If it's to the heart, it can cause a myocardial infarction, which is a heart attack. Some risk factors for thromboembolic conditions are atherosclerosis, which is the formation of fatty plaques within the walls of the arteries. Inflammation is another risk factor. Anything that causes stasis of blood flow, so slowing of blood flow or blood flow not moving properly due to immobility, these are all things that can increase risk factors for clotting. For drugs that are used as anticoagulants, aspirin, which is an antiprostaglandin, it blocks something called thromboxane A2. Heparin is an anticoagulant as well, and warfarin is used for those that are prone to atrial fibrillation, and what it does, it interferes with the action of vitamin K. Vitamin K important for clotting. Dabigatran also functions as an anticoagulant by directly inhibiting thrombin. So all four of these are anticoagulants. Now, a thrombocyte is a platelet, right? And penia means decrease. So thrombocytopenia is a decreased production of platelets. Petechia, if I'm saying the word right, I always seem to mess that word up. These are small purple blotches on the skin. It's due to spontaneous widespread hemorrhages. Remember, we have to look at the function to help us understand a dysfunction. If thrombocytes cause clotting, like essential clotting to prevent bleeding, we're going to wind up having hemorrhaging if we have a decrease in these things that stop bleeding. What would cause it? Well, suppression or destruction of bone marrow, red bone marrow specifically, could do that. That could be caused by a malignancy. It could be caused by radiation. It could be caused by certain types of drugs. I won't ask this question on an exam, but if the platelet count drops below 50,000 per, I believe it's microliter, that's diagnostic for thrombocytopenia. The treatment is with a transfusion of concentrated platelets. When we talk about bleeding disorders, impaired liver function would lead to impaired bleeding. The liver makes procoagulants. So if there's impaired liver function, there would be an inability to synthesize these procoagulants. This can cause, or causes of it can include vitamin K deficiency. I mentioned vitamin K being essential for coagulation. Hepatitis, which is a liver disease, an inflammatory liver disease, and cirrhosis, which is progressed liver disease, can also impair liver function, impairing the synthesis of these procoagulants. If we have impaired fat absorption and liver disease, it can prevent the liver from producing bile, right? So bile is necessary, we haven't learned yet, but in the digestive system, bile is necessary to absorb fat. So by not producing bile because of the liver disease, we're not absorbing fat well. By impairing fat absorption, we impair fat-soluble vitamin absorption, and A, D, E, and K are fat-soluble vitamins. We just said vitamin K is essential for coagulation. So we kind of see this cycle happening, whereas if there's a vitamin K deficiency, it can affect liver function and ability to produce these procoagulants. But also if there's impaired liver function, then we don't produce bile as well, whereas we don't absorb fat-soluble vitamins as well, like vitamin K, that's necessary for those procoagulants. So you can kind of see this cycle go round and round. Hemophilia is a hereditary bleeding disorder. It is due to a lack of a clotting factor, and you have hemophilia A, B, and C. A is the most common type. It is a lack or deficiency of factor 8. Hemophilia B is a deficiency in factor 9, and hemophilia C is a deficiency in factor 11. Now, the treatment is not only blood transfusions, but also injection of whichever factor is missing, depending on which type of hemophilia it is. The reason this is very dangerous is because, well, especially in children, is because if there's internal bleeding, sometimes it's hard to know that there's actually bleeding internally, and if there's no clotting and the bleeding continues, obviously that can result in massive blood loss. DIC is disseminated intravascular coagulation. Now, that sounds like a really big word, but let's break it down. Disseminated means widespread. Intravascular means within the blood vessels, and coagulation is coagulating of the blood, right? So you basically have widespread clots throughout the bloodstream. That's what this is. So the clots, so here's some of the dangers. The clots can block blood vessels, as we mentioned before, with any kind of clotting in a healthy blood vessel. And also, you can have, in this case, you can have severe bleeding because the residual blood is unable to clot. And so you've got this kind of dual effect. Now, some things that can cause this are complications of pregnancy, septicemia, or incompatible blood transfusions. Now, when we talk about transfusions, whole transfusions are used when there's blood loss is rapid and substantial. We could also use packed red blood cells to restore oxygen carrying capacity. Now, if you have incompatible blood, and again, I've talked about blood typing on a different video, but if you have incompatible blood transfusion, you get this reaction where the blood coagulates, and so you wind up with clots forming. It's basically an antibody-antigen complex, and what's happening is the antibodies are clumping the red blood cells together. It's called agglutination, and again, it forms these clots. The dangers of that are that the blockage of the blood vessels, but also those red blood cells are going to rupture, leak out hemoglobin, and it can cause kidney damage. So we have the A, B, and O blood types, and I'm not going to cover the blood typing here, just some key aspects as we finish these last series of slides, and you can reference the blood typing videos for all of the ways to match up blood types. Now, another name for the antigens is agglutinogens, and another name for antibodies is agglutinins, okay? And so if you see that anywhere, you'll know. And you're named according to the antigens you have present. If you've watched the other videos, the antigen is the little flag or indicator. So if you have A antigens, you're type A. If you have both A's and B's, you're type AB. If you have B's, then you're type B. And if you don't have either, you're type O. This slide shows the different blood types, and it shows that if you have A antigens, you're type A. It also shows you which antibodies you produce. Remember, anti means against. So if I'm type A, I'm going to produce anti-B antibodies. If I'm type B, I'm going to produce anti-A antibodies. Type O produces both, and type AB doesn't produce either because they have both A and B antigens, and you have to understand and remember that antibodies attack the antigens they're specific for. So if AB had either anti-A or anti-B antibodies, then it would attack their own antigens, right? Because they have both A's and B's. So there is another antigen called the Rh antigen. It was actually identified in rhesus monkeys, Rhesus, and so that's where the Rh came from. And this is called the Rh factor. And if you have the Rh antigen on your red blood cells, then you are Rh positive. If it is absent from your blood, then you are Rh negative. Another specific thing to understand is that if you were exposed, so if you're Rh positive, you don't make anti-Rh antibodies because that means you have the antigen. If you're Rh negative, you have the ability to make anti-Rh antibodies. So, Rh positive can never attack anything to do with Rh. However, an Rh negative person could potentially make antibodies against an Rh positive person's blood. So keep in mind from my other videos, it's the recipient that always attacks. So if you give Rh positive blood to an Rh negative person, the first exposure actually sensitizes that person, and then they make the antibodies, so there won't be a reaction. A second exposure to the Rh positive blood will result in a transfusion reaction. Now I have an entire video talking about mom and baby and how this works. So if mom attacks baby, it's called the hemolytic disease of the newborn, or erythroblastosis fetalis. This can only occur in an Rh negative mom because what I say in the last slide, Rh positive person does not make antibodies, so there's nothing, or at least anti-Rh antibodies, right? Because they have the Rh antigen. So an Rh positive mom there's no danger for the baby. The danger is only potentially if mom is Rh negative. Now, if the baby is Rh negative, like doesn't attack like, plus Rh negative means they don't have antigens, or at least the Rh antigens, so there's nothing to attack even if mom did have Rh antibodies. If the baby is Rh positive, then the baby may be in danger because the antibodies can cross the placenta and destroy the baby's red blood cells, right? Now, this doesn't usually occur in the first pregnancy unless mom's been exposed to Rh positive blood, because we said the first time she becomes sensitized to it. If she is now sensitized, that means she has made the anti-Rh antibodies. If she then has a second pregnancy with an Rh positive child, that child would be in danger. If there is a reaction with mom and baby, the baby would be treated with pre-birth transfusions as well as exchange transfusions after birth. Now, there is a drug called Rogam, and what Rogam does is it prevents mom from becoming sensitized. What does that mean? It means that it prevents mom from ever making the antibodies if she is exposed to Rh positive blood. Remember, it has to be an Rh negative mom. Be very clear on this. Rogam doesn't work to block antibodies. It blocks the formation of them in the first place. So if mom has ever become sensitized by being exposed to Rh positive blood, so let's say she didn't get the Rogam shot for a pregnancy, right? And she had an Rh positive child. If that's the first Rh positive child, the child is safe, but any subsequent child that's Rh positive is in danger because Rogam doesn't block the antibodies. It just stops mom from ever making them in the first place. Once she's made them, the drug is useless for her. It doesn't work. So to get a little more detail on transfusion reaction, what's going to happen if you have a mismatched blood transfusion, remember the recipient's going to attack. So what's it going to do? It's going to attack the donor's antigens. So let's say I'm type A and I receive type B blood. I make anti-B antibodies because I'm type A, and it's going to attack the B antigens of the donor, okay? So the donor blood. What's going to happen is it's going to clump them together, right, causing clots in small blood vessels, also causing rupture of those cells, leaking hemoglobin into the bloodstream. So because we're losing red blood cells, we're losing oxygen carrying capacity. Because we're causing blockages, we have diminished blood flow and potentially loss of blood flow to certain areas. And then the hemoglobin is in excess is toxic to the kidneys, so it can lead to renal failure. Now, this is really important. Type O negative is the universal donor. A lot of people say, oh, type O is the universal donor. That is not true. O positive is not the universal donor because a negative cannot receive from a positive. A positive, however, can receive from both positive and negative. So O negative is the universal donor. Same thing for universal recipient. AB is not the universal recipient. AB positive is the universal recipient. Remember, positive can receive from both negative and positive, and negative can only receive from negative. This slide gives you a visualization of the agglutination process if we were taking blood and putting antibodies into serum that had specific antigens, whether it's AB, A, B, or O blood types. That wraps up the blood chapter. Make sure to watch the blood typing videos. If you have any questions, reach out.